Okay, so we'll continue on with the muscle system here. We left off at hormones, and so let's talk a little bit about the hormones that will affect the muscle system. Several key hormones, but a few that I really want you to understand and know. First is growth hormone. And again, when you take A and P2, you'll take the endocrine system, we'll go into a lot more detail about the hormones. But the growth hormone, this is secreted from the pituitary gland, and testosterone. These are primary sex hormones. They stimulate the synthesis of contractile proteins and the enlargement of muscles. There are also thyroid hormones. They elevate the rate of energy or increase the metabolism of cells, so they increase the consumption of energy sources. They increase the metabolism of active skeletal muscles. And then epinephrine, also known as adrenaline, this is secreted from the adrenal gland. Adrenal glands sit just above the kidneys, producing a substance that increases both the duration of stimulation and the force of contraction. The epinephrine, there are a cascade of substances, epinephrine, norepinephrine, dopamine, all of which will stimulate the metabolism of skeletal muscles. This is secreted primarily from the sympathetic nervous system. And again, next semester when we talk about the nervous system, there's a parasympathetic and sympathetic. Sympathetic secretes or is involved in the secretion of epinephrine that increases or stimulates the activity and the force of contraction from skeletal muscle. When you get scared by something and your heart beats, and you can feel your heart beating in your chest, it's because the force of contraction of the muscle is strong. If something scares you and you run, epinephrine is what's sending you that burst of energy, stimulating the skeletal muscle and increasing the metabolism. It only lasts for a short period of time. You get this short, quick burst of energy. You've heard the story about the mom lifts the car off the child that gets hit or something. It's that burst of adrenaline, the epinephrine, that causes that surge in strength of skeletal muscle. So some key points there of muscle. Muscle performance is based upon the distribution of fibers. Percentages of fast, intermediate, slow fibers in skeletal muscles can be quite variable. Muscles dominated by fast fibers appear to be pale, often referred to as white muscle. Extensive blood vessels and myoglobin in slow fibers give these fibers a reddish color. Muscles dominated by slow fibers, therefore, are known as red muscles or red muscle fibers. Now, these fibers in humans may vary. Most human muscles contain a mixture of fibers, so they appear somewhat pink in color. However, there are no slow fibers in muscles in the eyes or in the hands because the movements are swift, must be brief, and contractions are typically required. Many at the back of the calves are dominated by slow fibers. These muscles contract almost continuously to maintain upright position. So we see the distribution of these muscle fibers differently. You may hear on the media from time to time football coaches or media people get into trouble because they try to compare athletes of different races, whether or not white muscle fibers and red muscle fibers predominate in given individuals of different ethnicity. And so a lot of times it gets into trouble, but studies have been done to demonstrate that muscle fibers do differ compared to races, compared to different ethnic backgrounds. And so you don't get a lot in media about it, and now a lot of media folks and or researchers are hesitant to talk about it because they don't want to get labeled as saying something racial or whatever. But the fact remains, it is very true that genetically different individuals have different types of muscle fibers throughout their bodies. And so, and it's a pretty well-known fact, and those who do physiology and stuff can go into a lot more detail about it. If you ever want to read about it online, you can go in physiology and read about red muscle fibers, white muscle fibers, and their effect on athletic performance. Again, the process of hypertrophy. Now, I mentioned about hypertrophy before when I talked about how muscles can increase in size, not increase in number, but basically increase in size. In muscle hypertrophy, this is a result of repeated and exhaustive stimulation of muscle fibers developed. These muscle fibers basically develop more mitochondria, which is a higher concentration of glycolytic enzymes and larger glycogen reserves. Each myofibril contains more thick and thin fibers. The net effect is enlargement of the muscle. Now, the number of muscle fibers does not increase. It's the size of the muscle fibers that changes. So the muscle as a whole enlarges. It's not that the number of fibers significantly changes at all. Now, in muscle atrophy is when muscles are not regularly stimulated, and so they lose muscle tone, they lose muscle mass. There's a reduction in the overall size of the muscle, the tone, and its power. Muscles become flaccid, and muscle fibers become smaller and weaker. Now, muscle atrophy can be caused from two things. One is if you damage the nerve that innervates the muscle, then the muscle will atrophy. There's no longer stimulation. The muscle's not being used. The muscle doesn't need glycolytic enzymes. It doesn't need glycogen stores. It doesn't need mitochondria because the muscle's not being used. And the muscle will eventually get smaller and smaller and smaller. Eventually, it will begin to shorten because it doesn't have the elasticity, the strength anymore. And so when that occurs, that's a process of muscle atrophy from the damage of the nerve. You can also immobilize the muscle. You can put a cast on an arm, and because you don't use that arm for 6 weeks while the cast is on, you're not exercising the muscle. There's a decreased need of energy to that muscle, so mitochondria begins to drift away. Glycolytic enzymes, nutrients don't go to that targeted area because it's not being used, and so the muscle will again basically get smaller and smaller from non-use. Take the cast off, start exercising the arm, the muscle will again begin to recover and return back to its normal size. So two processes there. One, muscle hypertrophy, repetitive, exhaustive exercises. Muscle has memory, so the muscle knows I need more mitochondria, I need more glycolytic enzymes, I need glycogen stores, glycogen reserves. So that muscle fiber gets bigger. Doesn't increase in number, gets bigger. That's hypertrophy. Atrophy, you're not using the muscle either because the nerve gets damaged or because you immobilize the muscle. Either way, the muscle will become smaller. The number of fibers will basically get smaller and smaller and smaller. Now, when I say the fibers get smaller, not the total number of fibers, it's just that they get smaller. Okay. Now, effects of muscle atrophy, individuals that are paralyzed by spinal injuries, damages to the nervous system. Otherwise, we'll see that these muscles will lose tone and size. Even temporary reduction in muscles can lead to muscle atrophy. You can easily see that again when we're using a person that's been casted. Muscle atrophy initially is reversible, but a dying muscle that you haven't used for a prolonged period of time, causes extreme atrophy. That person will eventually have a permanent impairment because the muscles will basically contract and scar into that position, and you'll never be able to regain full use from that. Two concepts that I want you to know: definition, origin, and insertion. Origin and insertion. Test questions. Origin, the place where the fixed end attaches to the bone, cartilage, and or connective tissue. Insertion, the site where the movable end attaches to another structure. The origin is typically proximal to the insertion site. Muscle action, I think I did both of those, yeah. All right, now muscle action, most and all muscles either originate or insert on the skeletal system. When a muscle moves or a portion of the skeleton, that movement is involved in different types of positioning. Those positionings include flexion, extension, adduction, abduction, protraction, retraction, elevation, depression, rotation, circumduction, pronation, supination, inversion, eversion, lateral flexion, and or opposition. Each of those are particular movements that you see in the body. This whole concept of muscle origin and insertion all allows the muscles to move in given motions. One segment of your book goes over what's referred to as the lever system. There are a number of different types of lever systems. I won't go into a lot of detail about each of the levers, but basically this is where a lever is a rigid structure, such as a board or a crowbar, and or in our case a bone that moves on a fixed position referred to as a fulcrum. child's teeter-totter is the example that your book uses, where you see a seesaw provides a familiar example of a lever, opposing forces causing a particular movement to take place. In our particular case, we have a fixed position where the muscle basically attaches to a movable portion, which causes this fulcrum action or this lever action to take place. Levers can change the direction based on the applied force, the distance and speed of movement produced by the applied force, and then the effective strength of the applied force as well. These illustrations that I'm showing you are basically just different positionings of muscle, looking at origins and insertions and the different lever actions that can take place. Again, seesaw is a first-class lever, and again, I won't go into a lot about the lever system here. Second-class second-class lever is basically resistance is located between the applied force and the fulcrum. Then a third-class lever, which are the most common in the body, we see a force is applied between the resistance and the fulcrum. Example is like a ladder that you raise it, you lean it against the building. The fulcrum is the base of the ladder, which contracts on the ground. The force applied is when you grasp the ladder and the resistance of height. The effect is a reverse of that of the second-class lever. Again, we see different levers throughout the body in different positioning. Now we're going to look at different muscle groupings. And what I will do on the lab, there are so many muscles in the body. And I'm not expecting you to know every muscle of the body. I'm not expecting you to know all of the origins and insertions in the body of the muscle grouping. For the labs, I'll post the muscles that you need to be familiar with. And so, particularly for the lab, you'll just need to make sure that you're able to identify those muscles that I list for you there. And you use your textbook, but remember, I mean, we could spend a semester just on the muscle systems and the number of muscles that are involved. But there are some key muscles that you need to be familiar with. Primarily, I will focus on muscles that I think you're going to have experience with clinically. So just make sure you follow that list when you do your lab assignment. Now, we've talked about two skeletal systems, axial skeletal system, appendicular skeletal system. Separation of the skeletal systems based on axial and appendicular skeletal systems will also see that the muscles will be based upon those muscle systems between which they will work with. The axial musculature arrives from the axial skeletal system, positions the head, the spinal column, moves the rib cage, assists in movement that makes breathing possible, does not play a role in the movement or support of either the pectoral girdle or the pelvic girdle limbs. Category will encompass about 60% of the skeletal muscles of the body. The appendicular skeletal system stabilizes and moves components of the appendicular skeletal system. Obviously, that's the pectoral girdle and the pelvic girdle, all those muscles not covered by the axial skeletal system, which are 40% of the skeletal muscles. These are just the external muscles that we see in the body, and this is the anterior view. Again, this list looks pretty extensive. Many of these muscles you will at least be familiar with, or you'll probably know by the time you finish studying the system. These are muscles, again, seen posteriorly, but now remember, these are the external muscles. These are the most superficial muscles that we see. Peel off a layer, then you'll see additional muscles laying underneath. And those are just the muscles externally. Remember, there are muscles also in blood vessels. There are muscles in organ systems of the digestive tract, smooth muscles. There are muscles in the cardiac system as well. Primarily, we're going to focus on the muscles for axial and appendicular skeletal system. And then as you go through each of those specific organ systems in A&P2, we'll bring up these muscles again, and you'd have to be able to identify those muscles at that particular time. So again, let's get back to the nervous system, which has to innervate the muscles. Innervation, you should know this definition, distribution of nerves to a region or to an organ. Many of the muscles of the head and the neck are innervated by cranial nerves. Now, when we think about nerves, some nerves come directly off the brain, innervate the muscles of the face, some of the upper muscles of the neck. Some even will travel and innervate some digestive organs, but cranial nerves come directly from the brain. Those little holes that you studied, the foramen in the skull, the little cranial nerves will pass through those little foramen. They come directly off the skull, cranial nerves. Then there are nerves that come off the vertebral column, spinal nerves. They come off and innervate skeletal muscles further down in our body. So innervation, basically distribution of nerves from particular regions or organs. Many muscles of the head and neck innervated by the cranial nerves. When you do the nervous system, you'll have to know the cranial nerves. That'll be second semester. Originate from the brain, pass through the foramina of the skull. Alternatively, spinal nerves connected to the spinal cord pass through intervertebral foramen. Again, axial muscle groups, 4 groups: muscles of the head and neck, vertebral column, rectus muscles, muscles of the pelvic floor. These are some of the muscles of the head, as you can see, and I'll list the muscles that you'll have to be familiar with. Most of these will involve muscles of facial expression, muscles that involve whether we can smile, whether we grimace, muscles involving whether we can eat, muscles of mastication. We also have muscles that will involve positioning of the head and neck, sternocleidomastoid muscle, muscles of the neck and upper back trapezius muscles, depressors muscles, orbicularis muscles, all of which we'll kind of go over. This is an anterior view of the face and the muscles of the face. Remember, we talked about the tendinous process that attaches to bone. This is an example of the aponeurosis, where the endomysium, perimysium basically will taper off and will attach and insert into the skull. This is referred to as the epicranial aponeurosis, again a wide tendinous structure. Frontalis muscles, the orbicularis muscles, orbicularis oculi muscle, the orbicularis oris muscle. Spelling is going to be a big issue here, I can tell. Nasalis muscle, procerus muscle, mentalis muscle. Again, I'll list all of these out for you as far as what the key muscles are. And then I'll group them for you as well. They're muscles of facial expression, muscles of mastication that you need to be familiar with, muscles that cause flexion of the neck, muscles that cause posterior extension of the neck, so forth and so on. One group that we'll talk about just quickly are the extrinsic eye muscles. This is the largest group of facial muscles that's associated with, I'm sorry, this should be the mouth. This is extrinsic face muscles. This is orbicularis, associated with the mouth. That's labeled wrong. I am so sorry. These are muscles of the mouth, the orbicularis oris muscle, which I showed you on the earlier slide. Muscles constrict and opening other muscles of the lips and the corners of the mouth. There are the buccinator muscles that has 2 functions that's related to eating. During chewing, it cooperates with the masticatory muscles by moving food back and forth across the teeth and the space inside the cheeks. In the infants, we'll see the buccinator muscles provide suction and suckling of the breast. Sometimes they can cause dislocation of the ribs, but no, just kidding. But that's an aggressive breastfeeding. That's an inside joke, and those of you who are listening on media probably can't appreciate the joke, so I'm sorry. But anyway, I'm going to go back to this illustration again where you can see the orbicularis oris muscle. You can also see the muscles of mastication, which will include the masseter muscle, the buccinator muscle, depressor anguli oris muscle, depressor labii inferioris muscle. All of these muscles are involved eating and or chewing. And then we will talk about the extrinsic eye muscles. I'm sorry that's labeled. Again, that should be muscles of at least of the around the mouth. Then the extrinsic eye muscles, which is the correct muscles now that we'll talk about. The extrinsic eye muscles. There are 6 extrinsic eye muscles of the that are involved, also known as the extraocular muscles or oculomotor muscles, originating on the surface of the orbit, and they control the positioning of each eye. And these are important muscles, and it's important for you to appreciate how these muscles have to work together to position the eye. Because remember, the eye has this ability to track, and remember the eyes, when the muscle contracts here laterally in the left eye, if we say that the lateral muscle has to contract to move the eye to the left, then the muscle here in the medial aspect of the right eye has to contract to be able to allow the right eye to track with the left eye, and you know that the eyes move in coordination. So there's this series of opposing relaxation and contractions that must take place in the eye. But also the eyes can move 360 degrees in an anterior plane. They can move 360 degrees, and so there are other muscles that must be involved to allow that to take place, and these are the extrinsic muscles of the eye. Inferior rectus muscle, medial rectus muscle, superior rectus, lateral rectus, inferior oblique, and are the superior oblique muscles. Extrinsic eye muscles are innervated by the third cranial nerve, the oculomotor nerve, the fourth cranial nerve, the trochlear nerve, the sixth cranial nerve, the abducens nerve. These are all cranial nerves. You do need to know the names and the numbers for those nerves. Extrinsic eye muscles, again, innervated by the third, fourth, sixth cranial nerve, oculomotor, trochlear, and the abducens nerve. Now this is an illustration again out of your book that demonstrates to you those extrinsic eye muscles. And looking at these muscles from a frontal view or an anterior view gives you a little better appreciation for what they do. As you can see, the medial rectus muscle, that's located medially, when it contracts, it's going to move the eye toward the nose. Think of the nose as the midline, that's the medial surface, so the medial rectus muscle will move the eye medially or toward the nose. Medial rectus in the right eye, medial rectus in the left eye. Remember, when it contracts, it's going to move that eye toward the nose. Lateral rectus muscle is going to move the eye toward the side. So when the lateral rectus muscle contracts in the right eye to move my right eye toward the lateral surface or over my right shoulder, then the medial rectus muscle in the left eye has to contract to move the left eye, because the eyes have to move in coordination. Very few people have the innate ability to move their eyes in opposite directions. Some do. But basically, you see opposite muscles being affected in this anterior plane to allow the muscles to move in this direction. Now, the superior oblique muscles and the inferior oblique muscles are a little bit different animals. As you can see from the positioning of this muscle, when it pulls, it causes the eye to rotate superiorly and also medially, or in some cases, when we see the contraction occur in the inferior oblique muscle, we'll also see lateral movement as well. So when the eyes are moving in 360 degree anterior planes, we see more of the involvement of these oblique muscles, causing a particular movement, or brings the eye into this 360 degree plane. Also has to be coordination with both the medial and the lateral rectus as well. Now, the question that I asked you on the exam involves the medial and the lateral rectus muscle. It gets a little more confusing when we started bringing in the inferior and superior obliques. You should be able to identify those muscles, but as far as functioning, I'm going to ask you either about lateral medial rectus. I may ask you about superior inferior rectus as well. Superior rectus contracts, the eye moves up. Superior rectus contracts, the eye is going to move up. Inferior rectus contracts, the eye is going to move down. And again, that's usually coordinated movement between both eyes, because movement is usually symmetrical. So you should be familiar and should be able to identify each of these muscles. You should understand the basic functioning of the medial and lateral and the superior and inferior rectus muscles as well. Another grouping of muscles are the muscles of mastication. Muscles of mastication move the mandible at the temporomandibular joint. There's a large masseter muscle, which is basically the strongest muscle of the jaw. Temporalis muscle, which assists in the elevation of the mandible. Gritting of the teeth while resting on your hands on the side of your face, you can do that. The pterygoid muscles, used in various combinations that help elevate, depress, protract the mandible and slide it from side to side. The movements are important in making it efficient for the teeth to grind and to chew foods. The muscles of mastication are innervated by the fifth cranial nerve, also known as the trigeminal nerve. You should know that as well. Cranial nerve, fifth cranial nerve, trigeminal nerve, muscles of mastication. This illustration, again out of your textbook, demonstrates some of the muscles that are involved here. Temporalis muscle, masseter muscle, then the pterygoid muscles, lateral pterygoid, medial pterygoid muscle. There are muscles of the tongue, another grouping. Usually tongue muscles have the term glossus, which refers to tongue, and so we'll see that as the suffix in many of those words: palatoglossus, styloglossus, genioglossus, hyoglossus. The names pretty much would be self-explanatory, meaning that these muscles will originate at a particular area. The palatoglossal originates at the palatine bone. The styloglossus originates from the styloid process. So this is where the names, the hyoglossus originates from the hyoid bone here anteriorly in the neck. And so typically those names help to tell you what the origin and insertion are. Origin and insertion questions for the test typically would be based upon this grouping of muscle. If I asked you the origin of a muscle and it was palatoglossa, you would know that the muscle originates at the palatine bones and then inserts in the tongue. Muscles of the tongue, again, this illustration out of your textbook shows you some of the key muscles that are involved here, and then these are some of the other muscles that are involved as far as elevating and lifting, especially in the swallowing mechanisms. If you remember no, sorry, that's not in this class. If you remember. When you study the digestive system, when we talk about the swallowing mechanism, you'll have to appreciate each of these muscles and their particular function. For you, I would just expect you to be able to identify the muscles, but when you get into A&P2, not only would you have to identify the muscles, but you'd have to identify the functions of the muscle as they affect swallowing. Some of these muscles involve tensor veli palatini muscle, levator veli palatini muscle, laryngeal muscles. They're constrictors that actually, when we swallow, there are two tubes in the back of our throat. One goes into the lung, the other one goes into our throat. There's a common area, the pharynx, the posterior oropharynx, where those two tubes sit and are located. These muscles are responsible for closing the glottis, lifting the glottis up, opening up the esophagus, and letting food fall into the GI tract instead of allowing food to fall into the trachea, which would cause some obvious respiratory problems. So these muscles are involved in that process. Muscles of the pharynx are responsible for initiating swallowing. Pharyngeal constrictor muscles, superior, middle, inferior, move materials into the esophagus. Laryngeal elevator muscles elevate the larynx. Two palatine muscles, basically tensor veli palatini, as I've already referred to, and the levator veli palatini. They elevate the soft palate and adjacent portions of the pharyngeal walls. And as a result, again, when you swallow, it is important that these muscles coordinate which direction the food is going to be passed in. Also, as you can see, there's also an opening that leads into the internal auditory canal. Internal auditory meatus, I think is what your book refers to it as. But it's a little tiny tube that leads from the inner ear and actually connects into the walls, the adjacent walls of the pharynx. And so because of that, if you're in an airplane, if you swallow real hard, you can kind of increase the pressure in that tube and pop your ears. Also, that's why I say when you're flying, chew gum, because it actually changes the pressure inside the tube of your ear, because there is communication between the auditory canal and the pharynx. Little children a lot will get ear infections because they get bacterial infections in their throat. It migrates up the internal auditory canal, or internal auditory meatus. Your book says meatus, or do you remember? Say meatus or canal? Meatus. And so it can migrate. Their tubes are really short. And because their tubes are really short, the bacteria doesn't have to migrate. And as we grow older, quote unquote, and we grow out of ear infections, it's just because the canal gets a little bit longer, and so our antibodies would have a chance to fight off the infection before they can migrate to the inner ear. But when you're small, the tubes are really short, and so bacterial infections can migrate pretty quickly. And there is a communication there that will help. These are some muscles of the anterior neck. Again, if you follow the list that I post on Blackboard for your lab, these show you, again, you can see the hyoid bone, and as you studied that in the skeletal system, very small bone in the anterior portion of the neck. Very small bone, but you can see why this bone is so important. Even though it's small, multiple attachments occur at the hyoid bone. That's why if this bone is broken, and I don't know if Dr. Sloan went into detail about that, if this bone is broken, it can cause significant respiratory problems because it allows the muscles of the anterior neck to collapse. And when those muscles collapse, it closes off the airway. There's not a fixed point by which these muscles can suspend the tissue that they support. And so if that muscle is broken, it can lead, if that bone is broken, it can lead to major problems. Also, because of its location, again, you know, the carotid arteries and the jugular veins lie very close here. When bones break, they become razor sharp, and so this bone can cut tissue below and lead to significant problems. But some of the muscles here, important, their names are based upon their attachment to this bone: geniohyoid, stylohyoid, thyrohyoid bones. And then the digastric muscles, which typically have more than one belly. You have an anterior and posterior belly of this muscle. Anterior belly we see runs very anteriorly, whereas the posterior belly actually runs a little more laterally. But again, they attach to this hyoid bone. The omohyoid has a superior and inferior belly, and a lot of the muscles that we talk about will have that. One of the muscles that's important for you to know and be able to identify will be the sternocleidomastoid muscle. Sternocleidomastoid muscle is important because not only is it a muscle that's involved in flexion and rotation of the neck, but it's also a major landmark here in the neck as well. Major blood vessels will course medially and posterior to the sternocleidomastoid muscle. And so one of the ways that you'd be able to find the carotid pulse, or to be able to find the jugular vein, the internal jugular vein. The internal jugular vein is used a lot for vascular access. So when you're starting a large bore IV, typically what physicians will do is they'll palpate for the belly of the sternocleidomastoid muscle, and then insert the needle based upon feeling that muscle, and not based upon feeling the pulse, but actually based upon feeling the muscle, because you know that the blood vessel lies medial to that muscle. So it's an important muscle to be able to identify. Muscles of the neck: digastric muscle overlies the broad, flat hyoid muscle, which provides muscular floor of the mouth, aided by deeper geniohyoid muscles that extend between the hyoid bone and the chin. Stylohyoid muscle forms a muscular connection between the hyoid bone and the styloid process of the muscle. Main muscle that, again, I want you to be familiar with: sternocleidomastoid muscle. Also, if you're able to say that when you go home, your parents know that they're spending their money well. Sternocleidomastoid muscle extends from the clavicle to the sternum to the mastoid region of the skull. The omohyoid muscle attaches to the scapula and the clavicle of the first rib and the hyoid bone. And then the other members of the group are strap-like muscles that extend between the sternum and the larynx, the sternothyoid or the hyoid bone, and then the sternohyoid, and then between the larynx and the hyoid bone, the thyrohyoid bone. Okay, I think we'll stop there, and we'll pick up next week with the muscles of the vertebral column. We'll finish that up, and then we'll go into the appendicular muscle system. Finish there. Okay? Thank you.